let me introduce myself. I'm Izan, a fourth-year medical student in University of Malaya. Today, we are very honored to have invited Associate Prof. Dr. Aizura as our guest speaker. She is a consultant obstetrician and gynecologist at University of Malaya. Prof. Aizura has completed her MBBS degree as well as Master in Obstetric and Gynecology from and proceeded with fellowship in gynecological endoscopy and minimally invasive therapy in Taiwan, as well as clinical fellowship in reproductive medicine in Belgium. She is also currently the vice chair of Young FH Group and current president of Medical Alumni Association, as well as our college master for College Kediaman Ibnu Sina. And she is very passionate in teaching our curriculum and helping our medical students, as she is the program coordinator for our obstetric and gynecological posting and exam, as well as she is the head of our CSU. We are really grateful to have her today. So now I will pass the floor to Prof. Aizura, and I will share the screen as well.
Okay, so Eden, would you like to present it, and then we will present it together so that I can also comment?
Okay, so we'll start the discussion now.
Yeah.
So we will be discussing about one case today. This is Madam Siti, a 27 years old Malay lady, para 0, subfertility for the past 5 years. Last menstrual period is since June 2020, unsure of dates. So she has prolonged menstrual bleed since 9 months ago. Heavy flow for 10 to 15 days, then she will get intermittent spotting for few days, followed again by heavy flow. And on heavy flow days, she uses 7 pads per day. On spotting days, she will use 1 to 2 panty liners only. And if we compare this with previous,
I'm going to stop you there for a while.
Okay.
First of all, sorry. Thank you very much for inviting me. I apologize that we had to delay the session for half an hour, but I totally forgot that it's Ramadan and we have to, sort out our prayers and stuff and kepuasa and all that. So I thank you all for joining us today. Now, okay, that Madam Siti is 27 years old, all right? Now, she is subfertile for the last 5 years. So you're suggesting to me that she married at the age of 22?
Yes, correct.
Okay. And she has not bled since June 2020. That is like close to a year.
Yes.
Okay? All right. So interestingly, you say that she has heavy flow. She gets spotting and then heavy flow again. And menses will stop for up to 3 days and then she gets menses again. Okay. On heavy days, she uses 7 pads per day. I'm going to open it to the floor. In fact, let's have a active discussion here. Comment on that. What is 7 pads? Is 7 pads a lot? 7 pads is a little? How do you justify that?
Anyone feel free
to... Feel free to butt in. No problem. You can put your mic on. Feel free to discuss. We're going to make this an open discussion. Since I'm not in front of you, so you don't have to feel so scared of me. Come on. Yeah, let's have a discussion. This is a case-to-case discussion, right?
Yes.
Yeah, so we should discuss it that way. Are you happy? 7 pads per day. What would you consider as normal? What would you consider as heavy?
Anyone? It's okay, I will answer first lah. I will be the first.
Teruk lah macam ni.
Anyone want to give the answers? Come on,
you all just want to listen to a lecture on abnormal uterine bleeding, is it? I see.
Can I try?
You just do it. Don't try or whatever. Do it. Come on. Who is it?
Prof? Ridwan here.
Who?
Ridwan here.
Ridwan. Hi, Ridwan. Okay.
I would say 3 to 5 pads is normal. Beyond 5 is considered abnormal.
Okay. Then again, we have to ask what kind of pads does she use? Is she using maxi pads? Is she using the normal pads, the overnight pads? Okay, so all those things come into picture. All right. So technically, yeah, on an average, people will explain to you, oh yeah, I pakai overnight pads tu sampai 2, I lapik 2. Then you know that it's usually heavy. But having menstrual bleed is actually very relative to individual, and it really depends individually how much they use. Some people, they feel a bit more icky, so they tend to use more pads a day. Okay, some people, they can survive with fully soaked pads, 2 to 3 pads the whole day. So you know, you have to go slightly detailed into that lah. But when you tell me that it's blood clots overflowing, then it gives me an idea that it's heavy lah. Okay. All right, get that history right first. All right. Carry on, Injan.
Okay, so if we compare to her previous menses, she attend her menarche at 11 years old. All this while, the menses is irregular, but the menstrual flow, the duration is not prolonged. Usually it's 7 days, and uses 4 to 5 pads fully soaked per day on heavy flow day, usually day 1 to day 3. Otherwise, no instant menstrual bleed and no dysmenorrhea. So if we compare her previous menses pattern with the current menses pattern, we'll be able to think that there is a problem existing here.
Yeah. Okay. All right.
So the next one would be then I've asked about the anemic symptoms, since she has been prolonged bleeding for the past 6 months, 9 months. So upon an inquiry about the anemic symptoms, she actually have anemic symptoms for the past 6 months. Lethargy, dizziness, headache, reduced effort tolerance, palpitation, chest pain, but no syncope attack before this.
What is the first symptom that somebody who has been chronically bleeding or anemia would have? The first symptom.
Dizziness.
Dizziness. No, actually tiredness.
Right.
Okay, this lethargy, reduced effort tolerance. Did you manage to ask her, how did you get the NYHA class 2? You actually asked her?
Yeah, I asked her about her routine, whether she can climb stairs, get shortness of breath and climbing stairs when walking around, or yeah.
How many of you get shortness of breath when climbing stairs?
I do get shortness of breath when climbing stairs.
None of you. Usually in our class, usually in a class, if I will tell you guys, right, if you don't engage in a discussion with me, I will leave. So online also I can leave, you know.
Okay, guys, answer question, please.
Come on. Don't. If you know the fact that you're joining in this discussion, let's make it a little bit more viable lah. Let's make it a little bit more active. Takkan you just want to listen to like a podcast kind of thing only. All right, just undo your mic. And why is everybody on? I can't see your faces also. Why not enough Wi-Fi to support your video? Is it?
Guys.
It's always like this, is it? All the other case-to-case discussion also?
Yeah, usually it's a bit not that active. Yeah, but we try.
Yeah, you try. Okay, should I leave?
No. Hey guys!
Come on. When you're climbing stairs, how do you know that somebody is actually low effort tolerance compared to, you know, like exercising and having shortness of breath after climbing stairs?
Perhaps you see whether,
yeah, carry on.
Perhaps you see whether is it 1 flight or 2 flight of stairs that you suddenly get lethargy, because normally people 1 or 2 flights they don't get tired so easily.
Okay, so you've got to look at their fitness level. Who was the other one who spoke aside from Ridwan today?
Me, Belinda.
Hi, Belinda.
Yeah.
All right. So what did you have to say?
Probably the same, like how many flights of stairs and how many flights of stairs she has to take before she gets breathless.
All right. So I would probably say, under normal circumstances before, were you a fit and healthy person? Did you used to do activities? Were you exercising and all that? Climbing stairs, would it be a problem for you? Is it a problem for you now? So at least then I will also know whether there is a change in her fitness level. Okay? Once a patient gets palpitation, chest pain, you're talking about involvement of the heart already. Okay, you're already talking about involvement of bridging towards heart failure already. That's bad. That's bad. But somebody who has anemia over the 6 months, really she complained of chest pain?
Yes, yes.
Okay, all right. Okay, we'll go on first.
Okay.
Okay.
And other associated symptoms would be postcoital bleed since 9 months ago as well, and deep dyspareunia. So for these two features, any differential that we can think of?
Are you asking me?
No, I'm asking the floor.
Oh, you're asking the floor. Okay, because here I am looking at 3 different pathologies already. Anemia is one thing. Postcoital bleed, come on guys. Postcoital bleed is what to prevent otherwise?
Probably cervical pathology.
Are you asking me, Ridwan? Are you telling me?
Telling you.
Then put it in a answer mode, not a question mode. Say it again.
Cervical pathology such as cervical cancer or cervical atropine.
Cervical pathology. Okay, when there is a contact, and usually we have to rule out cervical cancer lah. 27-year-old, subfertility 5 years, cervical cancer, far-fetched or something for us to consider?
27-year-old is quite far-fetched for cervical cancer, but something we need to rule out as well.
You would need to find out further whether she had early sexual exposure. Okay, early sexual exposure, how many partners does she have? How many partners does her partner have? That sort of all those risk factors associated with cervical cancer lah. Okay, and what is it you said? She has blood stain over the penis and per vaginal bleed within 1 hour. Okay, what kind of bleeding is this? A lot?
Just like staining.
Staining. Okay, all right, carry on.
Okay.
Deep dyspareunia. Deep dyspareunia is what?
Anyone want to answer the question? When?
Aside from Ridwan and Belinda. Louis. Okay, Louis. Oh, maybe I should call out your names, huh? Or then they're going to start leaving the session already.
Someone is trying to answer just now, is it? You can just
Put up
answer
your hand or something. Yeah, put up your hand or something. Yeah.
Can it be adenomyosis?
Siapa ni?
Jajin.
Kan? Jajin. Ayah, these are all morning class punya orang lah. What did you say? Adenomyosis?
Could be adenomyosis.
Deep dyspareunia is only one thing for a medical student first and foremost. What is it?
Endometriosis, Prof.
Endometriosis. Full stop. Rule out endometriosis dulu. Adenomyosis is not usually described as having deep dyspareunia. Okay, now if you were listening to our session this morning, what causes deep dyspareunia?
Adenomyosis and also fibroid.
Deep dyspareunia. What causes deep dyspareunia?
Hi, Prof. A fixed uterus.
Yes, a fixed uterus where the endometriotic spots form adhesions over the uterosacral ligaments. And so that's why the uterus is not mobile. You need to be able to explain that. Then people will understand why. Kalau you kata endometriosis causes deep dyspareunia sahaja, people don't get the idea. Okay? Ni dah cakap dah pagi tadi, Esther. Do I call you May or do I call you Esther actually?
Esther is fine, Prof.
Okay. All right. Okay. Carry on, Eugene.
Okay. So now we will need to discuss about anything else that we can ask and the differential diagnosis that come in our mind when we until this point of time.
Okay. So why don't I let you all talk first and then I comment?
Yeah. So just unmute your mics and speak out your thoughts.
Good evening. So Belinda here again.
Yeah.
Can hear?
Feel free to
Okay.
talk. Yeah, can hear.
So probably maybe for the last menstrual period, since she can't remember the date, maybe you can just try to like find out if it's like in the early month, middle month, or late month, so you can get a more accurate read. Just a thought.
Okay.
And yeah, that's all for me.
Okay. But to me, I think that the date is actually not that significant because she has been bleeding for the past 9 months, and this is not an obstetric case lah. So to me, I think that because it has been bleeding for too long until the patient couldn't even remember the first day of the last menses period. This is the reason why patient couldn't actually remember when is the last menstrual period. Yeah, the first day. Anyone else have any thoughts? Feel free to speak up. Yeah, can talk about differential diagnosis, can talk about anything you have in your mind for now.
Hi, Fatin here.
Yeah, hi.
Hi, Fatih.
Okay, so I would like to ask about any bleeding tendencies such as epistaxis, any hematuria, because we're thinking of coagulopathy.
Yes, okay.
Okay. And also, I would like to ask about any symptoms of hypothyroidism, because hypothyroidism can also cause menorrhagia.
Yeah.
Okay.
Polymenorrhagia, that's correct.
Anything else?
Gum bleeding, bruising. In fact, yeah, you might want to ask whether she is also on any special drugs, any medication, or is she taking some herbal concoction. I know many people actually they have dysmenorrhea, okay, and because of dysmenorrhea they take some herbal concoction usually given by the sensei, and it actually makes them lose the pain, but it causes prolonged menses. All right, so I have a feeling that part of the pain is due to expelling out blood clots, so that's painful. So when the blood is thinner, then there's no more pain, but unfortunately it is now diluted, so it doesn't solve your problem. So you need to find out whether was she on any special remedy that was given by her friends or something. What is her biggest complaint? Is it heavy bleeding or prolonged bleeding or pain? Because she seems to have everything. She seems to have pain and bleeding and postcoital and everything. What is the chief complaint is upper?
Yes, so the chief complaint is actually the prolonged menses bleed, which brings the patient to the hospital. She says she bleed until tak tahan already for 9 months. Yeah.
Okay, all right, okay.
I could see some response from the chat as well.
Okay.
Prasad have said that the thing that he thought of is any iatrogenic causes, IUCD use, and any bleeding tendency as well.
Okay, Chop. Why would IUCD be not logical? Why is it not logical? IUCD. It's good that you are venturing into the idea, but I want to know why we should not. No, I wouldn't say should not consider, but it's far-fetched, super far-fetched.
Anyone? Or Prasad, you want to have a try to justify your point?
If it's too far-fetched, means it's maybe because the patient is trying to conceive, right? So why would they use OCP in the first place? Something like that.
IUCD. Why would you want to use IUCD if you're trying to conceive? Hi, Prasad. Thanks for joining.
Yeah. But
Okay.
I was just thinking of the iatrogenic causes, so I just wrote it down.
Iatrogenic causes like what? Sexual toys wouldn't give you a bleeding for 9 months, right? What kind of iatrogenic causes do you think? I would think that taking herbs is an iatrogenic cause.
Yes, Prof. Yes.
Something like that.
Mm.
Ong wants to say something. He put up his hand. Hao Xiang. Ong Hao Xiang, is it? I thought I saw the name just now.
You can just unmute and speak
Yeah,
up.
Hao Xiang, that's right. Tak jadi. Okay lah, alright lah. Jen, so common important history taking points missed by the students. Apa lagi?
Apa lagi?
What else? So at the moment, what differentials are we dealing with now?
Okay, so the next one. Can we use this palm coin?
Okay, this
In
is
your
something new. This is something new that I've come across. Did you coin this yourself?
No, it's a mnemonic. Yeah.
How you found this mnemonic? Is it?
Yes.
Okay. So it's actually quite good, interesting. If I knew this as a medical student, I would have done better. Okay. So as you can see here, palm coin shows polyp, adenomyosis, leiomyoma, endometrial cancer. Okay. So I can see in my mind, if I was as an attending physician, I would also go through it anatomically, meaning to say that I want to start from the very bottom. She's bleeding, right? So what is the most obvious? I would go for the local causes first. Look at her vulva, look at her vagina. What could be there? Could there be a tear? All right. But if it is a tear, it is not the sort of bleeding that is for 9 months. Right? 9 months of bleeding, right? She would definitely have gone into shock and required transfusion. But of course, you must see whether you can see anything dangling down there, like a polyp, all right, or really a cervix which has got chronic inflammation, cervicitis. Even cervicitis doesn't give you bleeding for 9 months. It gives you staining, gives you vaginal staining. Now, adenomyosis does not give you the sort of bleeding which is continuously for 9 months. Okay? What about leiomyoma? I agree. If it is a submucosal leiomyoma, which means that it is a foreign body inside the uterus, okay, keeps the uterus open all the time. Worse still, if you have a pedunculated submucosal fibroid, which hangs out, which keeps your internal os open all the time, of course, then you can get this persistent bleeding also. All right. What I cannot see here is polycystic ovarian syndrome. Is that ovulatory dysfunction?
Yes. Yep.
Yeah? Okay, so when you have, usually commonest reason is that lah. When you have an ovulatory dysregulation, that is the one which causes this prolonged but sustainable kind of bleeding. All right, if it is a malignancy sort of bleeding, it's usually fresh or smelly or necrosis, necrotic tissue will come out, that kind of a discharge more so, not bleeding, you know what I mean?
Yes.
Okay, iatrogenic, okay, Prasad mentioned iatrogenic, what does it mean? What is the description given here? Iatrogenic.
Also, like other traditional medication. Yeah.
Macam kita cakap tadi lah, like herbal meds and all that. Okay. And well done, Fatin. Fatin was the one who highlighted thyroid, was it?
Yes.
Coagulopathy and thyroid.
Yes.
Okay. Yeah, okay, I agree with this. We can use this.
Just to clarify, for PCOS, usually the bleeding pattern will it be really like prolonged until 9 months? What's the usual presentation?
PCOS will give you a history of no bleeding for quite some time, followed by maybe heavy bleeding, but usually it doesn't last for 9 months. Because the reason why they don't bleed is due to the end ovulatory cycles. which means that the egg doesn't come out. When the egg doesn't come out, everything goes haywire. Your endometrium also doesn't know what to do. So the cycle is not complete. So sometimes it is stuck at the proliferative stage. So the endometrial lining becomes thicker. But it doesn't get the signal to shed. So it just stays inside. And one day when it just decides to shed, it sheds, and that's when you have prolonged bleeding because you have a thickened endometrium.
Yeah.
For some people, they say that they have not bled for 9 months, for example. Okay, I'm going to reverse it the other way around. They have not bled for 9 months. You put a probe and then you see that the endometrial lining is actually very thin. So that also means that she has not ovulated for a very long time.
Okay.
Okay, so the PCOS doesn't present usually with prolonged. They may present with staining, but not perpetual bleeding for 9 months lah. Okay.
So anything that we can ask so that we can differentiate between polyp and leiomyoma, since both of them will present with prolonged menses bleed. Is there anything that we can ask?
Ask me or you want to ask your friends first?
Ask them first lah.
Okay. Go on.
Anyone have the idea how we differentiate between polyp and leiomyoma, since both can present with prolonged menses bleed? Any other features? Guys, any other features?
What do you know about polyps?
Yeah.
What do you know about polyps? What are
Any
polyps?
ideas?
Where do they exist?
Anyone want to give it a try?
Hi, good evening, Prof.
Hi.
Sorry, my mic wasn't working just now. I would just like to give a try. I think polyp is the proliferation of the endometrium as compared to leiomyoma, which is the proliferation of the myometrium.
Okay, so the polyp is usually, as you said, proliferation of the
Endometrium.
which
lining.
is softer. Okay,
Yes.
that is softer. The proliferation or an outgrowth of myometrial tissue is usually harder, firmer. I wouldn't say hard, firm. Okay, comes in a capsule. You know the characteristics of a myoma lah. All right, but tags, endometrial tags, overgrowth of the endometrium, sometimes even at the cervix. Right, what happened?
Hello. Sorry, my line got disconnected just now. Sorry.
Okay. All right. Okay. So these little tags can actually cause this incongruent bleeding. Okay. It's very funny because if let's say something is sticking out, all right. So of course that thing will, if there is contact with that particular thing, it can bleed lah. All right. But it must be a huge polyp or something which is so chronically, like very superficial blood vessels can be seen for it to be 9 months bleeding. Okay. All right.
Okay.
I'm thinking of endometrial cancer. How do we rule out endometrial cancer?
Endometrial cancer. Anyone have the answers? Anything that we need to ask for us to rule out or rule in endometrial cancer? Let's have
Bro, I think in regard to this case, as she's a very young lady, it is quite unlikely to be endometrial cancer. But apart from that, also we can do some investigations that to rule out whether or not this endometrial cancer. One of the common ones is to look for atypical cells on PIPEL sampling.
Right. Don't forget, if she has PCOS, she is predisposed to getting endometrial cancer too. If she has this persistent irregular menses or perpetually her endometrial lining is very thick, okay, that predisposes her to endometrial hyperplasia and subsequently endometrial cancer. So as much as I would like to disregard the fact that she's young, I think I would still keep it at the back of my mind.
Okay.
Mm.
From the chat, Hao Xiang have said that he's considering PCOS symptoms, so we can ask about hirsutism and also acne.
Yes, and you can also ask if her other family members also have hirsutism and acne, hairy, well, not to say ask whether you have hairy legs lah, but do they have a lot of hair? Okay, particularly on the legs, on the facial hair, and I think we spoke about it also in another class this morning. Find out whether they actually go for laser therapy on their to remove facial hair, waxing, threading, that sort of thing.
Okay. And Prasad have said that fibroid can grow in size and PIPEL. Yeah.
Okay.
And
Agree.
Ke-Ying have said that we can ask about constitutional symptoms, loss of weight, loss of appetite, and also family history of malignancy. Okay, that's it from the chat box.
Sorry, good evening, Prof. It's me again. I was wondering, based on the discussion just now regarding the differentiation of polyps and leiomyoma, is there any specific history, for example, the risk factors that give rise to these two? How do we differentiate them in terms of history and examination?
With leiomyoma, usually they don't get menorrhagia. With leiomyoma, unless you're talking about submucosal myoma, they don't. All right. Even with polyps, you can't see. So it's just this sudden onset of bleeding and this onset of bleeding which is on and off. But with menorrhagia, with leiomyoma, it doesn't usually come as a prolonged, long-standing bleeding sort of thing. They may get menorrhagia, but that is cyclical. Okay, not forever, unless you have this prolapsed submucosal fibroid which has now opened the internal os. Then you get that. So I think a lot of it actually is the differentials have to be complemented by physical examination.
Okay.
Thank you, Prof. So as you mentioned just now, is that your leiomyoma is usually much firmer and larger compared to polyp. Is it right?
Yeah. Yes.
All right. Thank you, Prof.
Okay. So, we can say that polyp usually present with prolonged menses bleed and leiomyoma usually don't, and usually they present with an abdominal mass which is growing in size. And malignancy, we can ask about constitutional symptom and family history, and ovulatory PCOS, then you can ask about acne and hirsutism. And adenomyosis, usually it's pain, usually it's a period pain.
Yeah.
Okay.
And with adenomyosis, you don't get huge masses. You get a bulky sort of uterus, but you don't get a, like a firm hard mass, suprapubic mass and all that. You don't get that sort of picture.
Okay. So adenomyosis usually is period pain, but you don't get a mass and you don't get prolonged menses bleed lah. Okay, so let's see what we have asked. So otherwise, she did not feel any mass protruding out from the vagina. So this question is like what Prof has said just now. You need to examine the vagina, see is there any polyp protruding out. So this question is in regards to this, where she did not actually feel any mass protruding out from the vagina, and there is no abdominal pain, no abdominal mass, and no mass effect symptoms, no per vagina discharge, no constitutional symptom, no MEDS symptom, no coagulopathy, as what
MEDS.
Fatin has said just now. Yeah, no increased bleeding tendency, no hypothyroid symptom, no ovarian failure symptom, and no IUCD inserted.
Why we ask ovarian failure? Wow, this one is menopause already. Hot flushes, mood swing, vaginal dryness.
There is one like premature ovarian failure, right?
Premature ovarian failure, how will they present?
Usually it's less menses.
Yeah. Less, and suddenly no more. Okay, they will not present with heavy bleeding. It is the perimenopausal women who will have heavy bleeding and then subsequently no bleeding and then suddenly bleeding again. That's when the erratic thing happens during the climacteric time. Okay, the perimenopausal women do have this problem. So if you are dealing with a slightly older woman, you have to consider that.
So for premature ovarian failure, usually it's like a immediate thing, like suddenly they don't get their menses, right?
That's premature ovarian failure.
Okay.
Perimenopausal symptom is different. Perimenopausal can feature like funny period, too much and then suddenly don't have, and then too little and then come again and then suddenly don't have. That kind of thing can happen.
Okay.
Okay.
Next one. So this is the progress. Initially, she went to Sungai Buloh and then referred to PPOM. So they have done transvaginal ultrasound, PPL.
Why she went to Sungai Buloh and Sunway and then referred to PPOM? Why was she referred to PPOM?
Because she actually stayed in Sungai Buloh. So she went to Sungai Buloh and then it's a long waiting list over there. And she go to private and then refer to PPM because she couldn't afford the medical fees.
So for financial constraints. So in actuality, at this point in time, you would already have known what Sungai Buloh and Sunway thought she has, right?
Yeah.
We're not supposed to reveal it now, is it?
Yeah. No, she was told to have polyps. Yeah.
Okay, how was she told to have polyps?
After they did ultrasound, transvaginal ultrasound, PPL, and also office hysteroscopy.
All that was done outside?
Sunway Medical Center, but office hysteroscopy is done here.
I see. Okay. Did I see this patient?
I'm not sure.
Okay, never mind. Carry on. Okay. Alright.
Okay, she was told to have she's anemic and she has polyps. Then throughout the 9 months, she was actually started with tablet Zingofer and then changed to tablet Obimin because she has iron deficiency anemia. But she stopped taking both because of the side effect of having constipation.
Yeah. Okay. Are you surprised?
No, I'm not surprised. Constipation is a quite common side effect for
which is why some of us give some other better iron preparation like iberate folate and sangobion. It reduces gastric effects and some of it is coated with sugar, so it's a bit more gentle to the stomach. Yeah, so that's why, but it is a bit more expensive, so not everybody can afford it.
I see. Okay. Next one is a past gynecological history. She did her pap smear in 2018, it's normal. And when she was 13 years old, she was diagnosed to have, she's suspected to have PCOS because all this while the menses is irregular. But she defaulted follow-up from since then onwards. So the diagnosis of PCOS is just suspected. Yeah. And the menstrual history is as mentioned above, and she never taken any OCP for contraception.
Okay, comment on the fact that she was diagnosed with suspected PCOS. Come on, guys. Hey, Ijen, it's like I'm having a private tutorial with you lah.
Come on, guys. Unmute your mic. Speak out.
MEDSOC took a lot of trouble to have this kind of discussion. And if you guys don't participate, it's such a waste.
Yeah.
right? I should be charging you 25,000 per hour or something like that.
Or you guys can just type in the chat
I
box.
can't see the chat box. Where's the chat box?
Chat box is the right upper corner there. There is a conversation. Yeah, you can click on it.
Conversation. Tak nampak. Okay, I want you to comment about the past gynae history.
Come, anyone want to comment? Just feel free to talk. Yeah. Or just type in the chat box. Come on, come on.
Are they all medical students, UM, or we have outside people?
There are some outside people as well.
Right. Hi, outside people. What universities are you from? And if you take the trouble to come and join us tonight, why don't you say a few words?
Okay, there are some response from the chat box.
I can't see the chat box.
It is too early to diagnose PCOS.
Okay, good point. Why?
Why?
Ah,
Keying, just speak out. Just unmute your mic. I think she's from university outside. She's a guest, yeah. Hello.
yeah, I'm talking to the wall.
She's asking when was her menarche. Her menarche was on 13 years old. 13.
Ah, well then, I thought I 11. Okay, now look at it again. Show me that slide again. The menarche slide. The menarche slide.
Here.
Okay, now if you see, all this while her menses is irregular, ranges from once every month to once every 6 months. So this poor girl, ever since the age of 11, she's never actually had proper regulated menses.
Yes.
You agree?
Yes.
Okay, so for the doctor to have diagnosed her, show me the gynae history slide again.
Okay. Hey,
Okay. So for a doctor to have diagnosed her at the age of 13, probably the mother would have brought her to see a GP and say that my daughter's menses is not regular, right? What if you were the GP, what would you have done?
Anyone? Yeah, someone is trying to speak.
Should refer to ONG specialist.
Should refer to who is speaking? Yugesh. Refer to ONG specialist. Okay, but to do what? At the age of 13, what can we do for this little girl? I knew she's 13, which means that she was probably not sexually exposed and everything.
Have to do more intensive investigation.
Like what?
Like to look from the hypothalamic. Started from hypothalamic.
Cakap lah. What do you mean? What do you want to do? What do you want to do?
Ultrasound.
You said how to ultrasound the hypothalamus?
For hypothalamus is mainly by history taking and by hormone level.
Yeah. Yugesh, are you from UM?
No.
Okay, tak apa. Alright. What we need to do now is to define. If you think that it is PCOS, so the thinking process should be what denotes PCOS. It would be helpful if we know the Rotterdam criteria. Okay, which would mean that an imbalance of the luteinizing hormone and the follicular stimulating hormone, a ratio of 2 to 1. A ratio of more than 2 to 1 suggests the first criteria of hormonal imbalance. The second thing that you can see obviously would be hirsutism. But in a 13-year-old girl, would you expect her to have hirsutism? Alright, I don't think so. Usually it's not that pronounced. However, do an ultrasound, and if you try to get a good bladder window, you may be able to see her ovary. And the ovaries may show polycystic ovaries, what looks like a string of pearls. That would be maybe indicative. And at the same time, you can also do what? Ijan, what can you do? Check her weight. Compare the weight and the height. Look for her BMI. Because we also know that with PCOS, you tend to have rapid weight gain. Okay, but in a 13-year-old girl, it's a bit difficult. But instead of giving her COCP, I would have monitored. If she was not bleeding, I'm not going to give her COCP. Imagine a 13-year-old girl taking medication every day. Definitely she will default. Okay, you got to teach her. She has to take 21 tablets, rest 7 days, take again 21 tablets. Will you listen? And it will depend. The side effect of the OCP that was given to her, she may have weight gain, water retention, so she's not going to be very happy. So I would have monitored her. At the most, if her endometrial lining is thick, I would have given her a progestogen bleeding regime, maybe for a course of either 5 days, and then make her bleed, and monitor, and then watch her ovaries. Then, if she's agreeable, do the hormonal assay, FSH, LH, estradiol, testosterone, free androgen index. I would have done instead of just leaving it behind. Because we know it is the most common reason for irregular menses is PCOS. But we allow teenagers some leeway because sometimes getting used to menses takes some time. So 11, 12, 13, usually we still kasih chan. Okay?
Regine have said that she think it was a misdiagnosis of PCOS.
Why?
Why? Regine, you have any ideas? Or
Hi, Prof.
Hey.
I think because since she achieved menarche at the age of 11 and this is at 13 years old, for the first 2 years of when we start when having menses, it's quite irregular, and then the flow is quite irregular, and there are times where it's an ovulation, right?
That's just the thing. I mean, I know for once that I had my menses at the age of 11, but I never missed a period. There are many people who actually have regular menses from the very beginning. But we assume that it's okay. That's what I'm saying. We give that leeway. So in a way, you're right. But 2 years, 2 years, and it doesn't she has gaps of 6 months, right?
Yeah.
It's too long. It's a bit too long. So sometimes I think moms should be a little bit more aware of whether or not their daughters are buying pads or requests for pads. Suddenly why no usage of pads at all or something like that. So yeah, we have to be a little bit more alert lah.
Yeah.
But I agree with you. I would say that the vast majority of people tend to just let go. And then they start getting a bit worried when the kid is about 15, 16. Agree?
Yeah. And Prof, I think it doesn't fulfill Rotterdam criteria.
Which one? She?
Yeah, her history. I don't know, because there wasn't any ultrasound done.
Nothing was done.
Yeah.
But it was quite brave of the GP to start her straight away on hormones.
Yeah.
I don't think we would have done that lah. I don't think we should have done that also. I think in doubt, always send her to be seen by a gynecologist, because we have pediatric adolescent gynecologists also. And at the same time, if she needs some endocrine help, we can always refer her to the pediatric. 13, do they still go under pediatrics?
Adolescents.
Adolescents, yeah lah, that's PAG lah.
Okay. Hao Xiang have said he would like to evaluate for clinical or laboratory hyperandrogenism.
Based on what?
As Prof you mentioned just now, the features of hirsutism, oily skin, acne, and serum free testosterone.
Ada ke tak?
But I don't think so.
don't know. We haven't gone to history, physical examination. Okay,
Yeah.
shall we just proceed and then we see whether we can pick up the case? See
Yeah.
whether anything else makes a bit more sense. Yeah.
Next one, past obstetric history, she is nulliparous. Then for the sexual history, because she has been complaining of subfertility for the past 5 months, past 5 years. So we need to ask a bit detail for the sexual history. So she has been married for 5 years but failed to get pregnant. Her husband is same age as her, 27 years old, who is a heavy smoker of 7 pack year and does not father any children before this. But otherwise, it's all well, no previous history of mumps infection, hernia surgery, or testicular torsion. They have regular unprotected sexual intercourse, usually 3 times per week prior to this event of prolonged menstrual bleed. And she's unsure about when is her fertile period because of her irregular cycles. But since 9 months ago, she only has very few episodes of sexual intercourse because of the prolonged menses bleed and also the postcoital bleed. They went to fertility clinic for checkup 1 year ago, but her husband haven't done any checkup yet. So initially, she was planned to be started on clomid induction, but treatment was postponed when she started having this problem, prolonged menstrual bleed. Yep.
I disagree. Why?
Why? Which part you disagree?
I disagree that should be started on clomid. Why?
Because the diagnosis of PCOS is not confirmed yet.
Achieved yet. The diagnosis of PCOS is not achieved. And how dare you do anything to this patient when the husband has not even done any checkup?
Yep.
It's not fair. Whenever you discuss subfertility cases, your opening statement must always be, we will need the couple to be present together, because the couple has to understand that investigation will include both the husband and wife. So there is too much to investigate for a woman. You have to investigate her eggs, you have to investigate her tubes, you want to investigate her uterine lining. So you go and put this girl through hell, and then suddenly you find out that she's all okay, but actually it is the husband who's got no ammo, no bullets.
Yeah.
So it's a bit unfair, no? So it is much easier to actually just take the sperm seminal fluid analysis, get that sorted out first, and then after that you can focus on the wife. Because you must remember, subfertility investigation, we know that the causes of subfertility is wanted. Wanted husband, wanted male, wanted female, wanted unknown cause.
Okay.
So, to avoid blaming each other and all that. Very common problem in Malaysia.
Yeah.
Okay. So she was planned to start on clomid. Unless she's not telling you that they diagnosed her with PCOS. Takkanlah the doctor so brave to start her on clomid.
But I really try my best to ask, like, did they investigate for PCOS? We say no. But they say.
What's the problem if she has PCOS? If she does have PCOS,
then it's hard to predict the fertile period because
not only that, clomid, if you give in a PCOS patient in a normal dose, can sometimes tip the patient over to ovarian hyperstimulation syndrome. And people are known to die and require ICU care if they actually go into OHSS. So be careful when you want to start someone on clomid induction, okay?
Okay.
All right.
So next one, no other past medical history, past surgical history, allergic history, and drug history. And for family history, there are no significant family members having ovarian cancer, uterine cancer, breast cancer, and colon cancer. And no fibroids or polyp history in her family members as well. And for the social history, it's just she works as admin in Sungai Buloh and her husband working there as well. They have been married for the 5 years, currently staying in Sungai Buloh. Patient doesn't smoke and doesn't drink, and husband is a smoker, and financially they are stable. Okay. Is there anything else that you would like to add before we proceed to physical examination? Hello? Pardon?
Who is talking? I'm not.
Oh. Or is there anything that we have missed out? Then you can give some.
I mean, I would of course like a more detailed social history lah. It is interesting that she got married at the age of 22. And what degree you graduate at the age of 22? Are they degree holders? Production executive, administration officer?
I didn't ask about that.
You can ask that. Married for 5 years, staying in Sungai Buloh. What is a 7-pack year? 7 packs a year?
No, 7-pack year, meaning he has been smoking for 7 years, 1 pack every day. So it's 7-pack years.
Oh, that's what they call it, is it? I didn't know.
Yeah, there is a formula of calculating pack year.
Oh, okay. Yeah. 1 pack a day? Okay, that's a lot, isn't it?
Yeah, it's a lot.
Okay. Financially, they are stable. I would have gone into, if I have the confidence of the patient, I would usually share the monetary number. What is it that they bring in? Total household income is how much? In Sungai Buloh, are they staying in a rented house or their own house, or they're staying with their parents or whatever? It does matter. If a patient is staying with her in-laws and all that, is she very stressed out because they're not having kids? Pressure from the mother-in-law, you never know. That sort of thing. So I'm more interested in that scenario. And if you talk about social history, why is it important? Because if let's say they cannot find the cause of the subfertility, are they game for IVF? And if you're talking about IVF, you're easily talking about an investment of 25,000 if in the private center. So are we even talking about that? Do they have the budget to consider IVF? So financially stable for me is very vague.
Okay.
Okay, so if you're interested to delve into fertility treatment, I think we need to know more.
Okay. So let's move on to the physical examination. So the physical examination finding for this patient. So generally, she appears to be very lethargic, but not in respiratory distress. And there are no PCOS features, no acne, no hirsutism, no oily skin, no oily hair. She is receiving infusion of IV zingofer. There is palmar crest pallor and conjunctiva pallor, which tallies with our suspicion of anemia. And pulse rate is 104 beats per minute, slight tachycardia, but regular rhythm and good volume. CVS examination shows ejection systolic murmur loudest over left sternal edge, probably is due to anemia, and the lungs are normal.
Yeah. So she is overweight?
Yeah, no, the BMI is 26.7, so it's
overweight.
Overweight in a Malaysian population setting.
Are we in the Asian setting, isn't it?
Yeah.
All right. Does she have a rapid in weight increase?
No, all this while it's around that lah, the weight. 60.
Okay. All right. She has no problem losing weight and all that also.
No.
Okay. All right.
Okay. Then let's move on to the abdominal examination. Abdominal examination, its abdomen is soft, non-tender, no mass palpated, and no hepatomegaly, no splenomegaly, no shifting downers, no bilateral pitting edema. So, anyone want to comment about the findings? Anyone want to comment about the findings? Currently, the only positive finding is she's anemic. She's receiving IV zingofer. And there is an ejection systolic murmur. And abdomen is soft. There is no mass palpated. So what can we rule out if there is no mass palpated? Anyone want to give an answer? Or just type in the chat box. Yeah. Anyone? Anyone?
I think they're all sleeping lah, way. You force them to join this session, is it?
No. Anyone? Come.
Never mind lah, they're not interested.
Okay lah.
They're not interested to participate. I also don't know why. I'm not surprised with these findings because a lot of masses, they don't have to be palpable. A palpable mass usually means that it is more than 12 weeks uterine size, which means that it's big. Okay, anything that leaves the pelvis already, like a fibroid or something, means that it's big. So again, as I said, if we are dealing with adenomyosis, for example, it's only about 12-14 week size uterus. But if you have a fibroid, not all fibroids also are palpable. If your fibroids are situated submucosal, you can't feel anything. If your fibroids are posterior, also you cannot feel anything because it just fills up your pouch of Douglas. So I'm not surprised. What I would like to know is, not only are the kidneys not blottable, do we have hydronephrosis? Later I want to find out whether there such things exist lah. That would be one of my things I would be interested in.
Okay, let's move on to the investigation. So these are the investigation done. First investigation, if a urine pregnancy test is negative, so we can confirm patient is not pregnant now. Then full blood count HB is 10.2.
10.2 for somebody who's having chest pain, headache, dizziness is a bit weird, isn't it?
I think this is the blood test that after the transfusion. Yeah.
Oh, tak boleh lah. You need to give me the one before the transfusion.
Before transfusion is about 8. Yeah, but sorry, I didn't type it there.
Even 8 also is, there are a lot of people walking around with the HB of 8, you know. A lot of my antenatal ladies actually walk around with an HB of 10. 9. Okay, carry on.
Then coagulation screen is normal. So this is important where we can rule out our coagulopathy. And then transvaginal ultrasound. Okay, this is interesting. There are no mass in, so everything is normal from the transvaginal ultrasound.
No mass in the transvaginal ultrasound. Okay.
Yeah.
But the ET is thick.
Yeah, ET is thick.
Despite the fact that she's bleeding for so long. Okay. Okay.
And the hysteroscopy and curettage shows polyps at the anterior wall of the uterus while entering. Yeah, this is the positive finding.
Do you think that the polyps is the cause of this bleeding?
But the ultrasound, it's all normal. There are no other pathology found.
Why is the uterine cavity distorted? Is it distorted because there's an indentation of a fibroid, or I don't know, you know? Is there a distortion of the uterine cavity making the surface area bigger, which is why she has this menorrhagia?
But they didn't specifically mention about that. Is there anything that we can do to further confirm?
No, but I agree that we should have done a curettage lah. For polyps itself to have caused this perpetual bleeding, okay, I'm thinking that polyps is maybe one of the reasons that can cause bleeding, but the polyps bleeding should not only be related to cycle. But if your menorrhagia is related per cycle, that means the heavy bleeding only happens during her cycle, then cannot be polyp, because polyps usually it will be there all the time. The bleeding will be perpetual.
But this patient bleeding has been there all the time, right? Has been there for 9 months.
Probably lah. Probably lah. Must be a huge polyp. Did they give a size?
No. Yeah, no. They just say multiple polyps. Yeah.
All right.
And then this is the HPE findings. So let's look at the comments there. They actually found that there are a small area of endometrial atypical hyperplasia. Yeah.
She's PCO. She is some amount of PCO, if not the typical PCO pun. There is some endometrial hyperplasia. Sorry, the blood investigation never checked the hormones,
No, never.
Why,
I also don't know.
You also don't know. Okay. Okay, all right. Carry on, carry on. I would have done some FSH LH here, isn't it? And then I would have tried to do a day 21 progesterone. But I am sure the day 21 progesterone will be, there's no day 21. Cannot. She has no day 21 because she has no menses, right?
Yes, yes.
I would have just done an LH FSH ratio. Yeah.
Is it because their current consideration is they want to find out why she bleeds, so they are thinking polyps, so the PCOS is like they will investigate PCOS later? That's the reason why they haven't did the hormone?
I don't know. I mean, if you're going to take her blood, why not take it all one shot?
Okay.
Okay.
Okay. So the management. So
Hey, wait, not done yet. HP balik. Let's see. So endometrial glands, no definite nuclear atypia, intraepithelial mitosis is frequent, no stromal desmoplasia. Make a habit to read your HPE. Susah-susah you belajar masa second year dulu. No malignancy is detected. Small area of endometrial atypical hyperplasia in the background of endometrial hyperplasia without atypia. Okay, so you can see here, if somebody who is young has endometrial hyperplasia without atypia, you can actually still do medical management. With atypia, you worry because atypia can progress to be cancer. So at the moment, the comment is hyperplasia without atypia. But you can see here that the pathologist is a bit like takut-takut. So that's why they kata atypical hyperplasia.
Yeah.
Which is weird. So that's why close follow-up is recommended. Okay. Take time to read your HPE. Don't just blast through it only. Okay? Okay, carry on.
So meaning this is not the typical finding of a polyps lah?
Definitely. The polyps, to me, I feel is an incidental finding. Her bleeding is because she has endometrial hyperplasia. Now, why she has endometrial hyperplasia? That is the next question. I think she has not been worked up properly. Even if she is not PCOS, there must be a reason why she has irregular periods. And because of her irregular periods and long chronic periods of no menses, there must have been endometrial thickness, which has now developed into endometrial hyperplasia. Commonest reason for this is PCOS.
Okay. So let's look at the management. Initially, polypectomy was done and sent for HPE. Then 3 weeks later, the HPE result is out and she was told to have endometrial atypical hyperplasia without atypia. So now they want to treat the endometrial atypical hyperplasia first, then only go for treatment for subfertility. So they discuss about delivery of the progestogen. Yeah. So patient chose about Mirena insertion. Yeah. So is there any, so is this the usual management for endometrial atypical hyperplasia, Prof?
I would not want to put a Mirena in a patient who is nulliparous. Can be a little bit uncomfortable.
Oh. So we will be choosing.
She has never had a different. I would blast her with high dose progestogen, medroxyprogesterone or noetesterone. Depo-provera for 30 milligram 3 times a day for the next. Try to shed the endometrium as much as possible. If this is a young lady, progestogen, high dose progestogen is the treatment of choice. If this lady was not contemplating pregnancy, I would have suggested for removal of the uterus.
Oh, okay.
Tapi because it's only hyperplasia without atypia. If atypia, I would have suggested the older woman to remove.
How
it
about
cancer.
atypia, but in her case,
We have
she's
to
a
give a
young
chance
lady.
lah. We have to give a chance lah because she wants babies, right? So we have to give high dose progestogen lah. After the high dose progestogen, then I will repeat a PIPEL or repeat hysteroscope and do a curettage and see whether that tissue has improved or not.
So even if her case, if this case is a case of atypia, we still can give a chance lah, since she really wants.
That is very patient doctor understanding. They have to understand because we know that atypia can progress to cancer. Yeah, so that is something that we need to discuss with the patient. Very, very detailed. For example, if let's say you give a course of 6 months of progestogen and then you repeat and it is still atypia, patient understand or not? What if it is, what if it is atypia, then we are worried about cancer. That's the thing.
Okay. So that's it for the management.
Wait. Again. 7 days before and 7 days after Mirena insertion to avoid ectopic pregnancy. Why they worry about ectopic pregnancy? There is an answer to that.
After
we discussed this also before.
Progesterone will cause muscle relax, so affect the peristalsis of the.
What? Yeah, causes smooth muscle relaxation. So that's why patients on Mirena have a slightly increased risk of getting an ectopic pregnancy, not patients on copper IUCD. Remember? We spoke about this before.
Yes.
Okay, carry on. So what happened after that?
That's it lah. That's the
That's
management for this patient. Yeah, that's it.
Okay. So follow up 6 months post Mirena insertion.
Yeah.
Wait. So after the 6 months insertion, they want to do a PIPEL. They want to do a PIPEL with the Mirena in situ.
No lah. I think they will remove the Mirena and then they do the PIPEL. Biopsy. Yeah. And if everything is okay, then only they proceed with fertility treatment. Or how about if that time still hyperplasia? Anything else that we can do?
Usually after a curettage, it shouldn't be hyperplasia lah, kan? Because you would have read a lot of the tissue already. And then you immediately start them on progestogen, so it should have thinned out the layer. So if it still remains as hyperplasia, then I worry lah. You might need to consider, I don't know, but this is a very sensitive issue to discuss for people who want to have babies. Maybe some of them will actually just try to get pregnant juga. But if it is difficult, then how? Because here you have to weigh the benefits to risk. If it is not cancer, are you willing to wait until it becomes cancer? I mean, I'm not an oncologist, so I can't really give you numbers on how soon does an atypia can change into malignancy. It might be worth you looking up into that and see how soon.
Okay.
Okay, so subsequent, lepas tu?
These are the investigation findings, the real investigation findings for our other important diagnosis. Yeah. This is a typical case of polyp. Yeah, the findings suggestive of polyp. So let's look at the vagina ultrasound. Same, there are no mass found, same as this patient as well. Office hysteroscopy, they are able to detect multiple polyp over the anterior surface. And the HPE report, as compared to the patient just now, they written there are no obvious cytological atypia. So the interpretation it's a benign polyp. Yeah. So is this, Prof? So is this the typical finding of a polyp?
That's quite common actually, and to comment that there's no cytological atypia is also quite common for all sorts of tissue. So yeah.
Okay, so next one would be, this is a fibroid case. So this investigation is for the patient with fibroid. So let's look. When we look at the transabdominal ultrasound, we already can detect there are a fibroid at the posterior part, more over the right side to the left side. Yeah. And they did a MRI pelvis, and they are able to detect there are ovoid subserosal myometrial lesion, and suggestive of leiomyoma. So is MRI usually indicated in the case of a menses, like in this type of case? Will you order MRI?
No. I'm not in the habit of ordering MRI. If unless I can see very obvious fibroids, or I cannot delineate fibroids, because for me the MRI is for fibroids, because I do myomectomy, so I want to know where I need to map out my fibroids. But if I can see that there are no fibroids, I don't need to do an MRI. If I think that the wall is thickened, I'll take the patient for an office hysteroscopy, so I can go in, have a look, one shot, and if I can do a biopsy, we'll do a biopsy immediately. Yeah.
Okay. So the last one would be adenomyosis. So this is the finding for adenomyosis. From the transabdominal ultrasound, we can see the uterus is globularly enlarged. Otherwise, no fibroid seen. So PIPEL is normal. Another case also the same. It's a globularly enlarged uterus, and the PIPEL is also normal. It shows proliferative endometrium. I have one question. How do we define enlarged uterus? How we know it's globularly enlarged? Is there a size or anything?
I mean, what is the normal uterus size?
6 to 9.
6 by 8, something like that, kan?
Yep.
6 by 8, 6 by 5 sometimes, depending on the size. So if it is like about 12, 14, yeah, so it's large lah. And globularly means it looks bulat. Uterus is like, the uterus looks like an RBC, right? It's got a discoid appearance, kan?
Yep.
Right? It's flat and you know, so a globularly enlarged is, it actually looks global.
Okay. That's it lah. Is there anything else, Prof, you want to add?
I'm not too happy with managing this patient. I think the polyp is red herring. The polyp is, by the way, we found it to be polyp. It's a very interesting case to have been discussed. And we can see that the discussion here, if you guys were following and were interested, actually that she needs to be sorted out even more. Okay? There's always this debate whether your need to get pregnant overtakes your risk of malignancy. Remember, we had this discussion before? Okay, now whether or not are you worried more about the hyperplasia or the atypia, or really you want to prepare your body as a vessel for pregnancy? I think sometimes people have to be a bit more, how do I say this, a bit more in line with reality over what is priority and what is important. I have many patients who actually bleed and irregular bleed. Some more husband pula duduk jauh. So kesian, it's very kesian. And they want to get pregnant, but they're having this bleed. So if only we can eradicate the bleeding process and then immediately embark on pregnancy, that would be great. But that's the element of subfertility pula. So somewhere along the lines, I think the doctors have not highlighted what is her actual problem. Okay, why is she having hyperplasia? What are the predisposing factors to give her hyperplasia? Here, it appears as though probably she's hormonally unstable. Maybe she's not ovulating. We have no means, no investigation to suggest why she has hyperplasia. That's why I'm thinking that could it be that it is an undiagnosed PCOS. So I think a lot more investigation and need to be done with regards to that rather than the polyp. Polyp, okay lah, you see it, you take it out, thank you very much, and she should stop symptoms. Is she still bleeding? We need to know. But now that she's on progestogen, difficult to say lah. Most probably she will not be bleeding lah. Okay, I hope that answers your question.
Yeah, there are a question from the chat box. Would a CT scan be necessary at this time?
To see what? What do we need to see? If you're worried about endometrial cancer, you think that there's torrential bleeding, you want to see whether there's spread of disease, yes. If you have already highlighted that it is endometrial hyperplasia, I don't think you need a CT scan.
Last question. If she was wondering if PCOS patient can ovulate spontaneously.
Of course. 20 to 30% of PCOS patients do not even know they have PCOS. So they are able to live life, get pregnant, deal with irregular menses or whatever. Nobody knows. You know, there's no. I'm sure you see there are a lot of ladies who actually are a little bit more hairy, but they don't complain. A little bit more chubby, isn't it? But tak ada masalah. Then you check, maybe for all you know there is 1 or 2 criteria which fulfill for the PCOS.
Meaning they can ovulate spontaneously, just that it's spontaneously, so it's hard to predict the fertile period. That's why it's important to get pregnant.
Yes, the problem with PCOS is that you have irregular menses. So what does the doctor do? You have irregular menses, the doctor will regulate the period. Once you regulate the period, you cannot get pregnant. So they're going to use hormonal manipulation. So what is the priority? You want to get pregnant or you want to have menses regularly? If you want to have menses regularly, you understand that you cannot get pregnant, but you can bleed every month. But if you want to get pregnant, then the doctors will have to help you to ovulate. That's when they use analogs, the GnRH and clomiphene and all that to make sure that you have your eggs, and then we time the egg and then we give you an injection, and 36 hours later, the egg comes out and say, okay, this is the time for you to have sex. We have to work with that.
Okay. And last one, why was ectopic pregnancy a concern?
I don't know. Oh, yeah, we spoke about that, about the Mirena. Yeah, we spoke about that. Who asked that question? Dia tak concentrate.
Okay. Yeah. That's it lah. No more questions.
Okay?
Yeah. So our session have almost coming to an end. Thank you so much, Prof. Aizura, for your time and effort.
I just want to find out, is the case-to-case discussion always like this?
Yeah, a bit not that active. Yeah.
Then don't bother doing it lah next time. I have to concentrate in their class cukup lah. I mean, I would do it if it was I would encourage it. I would continue doing it if everybody was actively participating, you know. Masuk sikit-sikit. I don't know. But I suppose it's a good experience for me too. Yeah. So
thank you so much for spending your time.
Also. Yeah. Okay.
So have a good rest today.
Yeah.
You, Prof.
You too. Yeah. See you guys tomorrow.
See you.
Bye.
Prof. So for all the participants, you can fill out the survey before leaving. The survey link is over the chatting box. Yeah. Okay. Bye, Prof.
See ya. Bye.
See you around.